Okay, now we're going to move on to our second speaker, Dr. Charles Bailey. Dr. Bailey is a pediatric hematologist, oncologist, and works in clinical informatics at the Children's Hospital of Philadelphia. His research focuses on secondary use of clinical data to better understand the nature of pediatric disease and to improve care for children. This has included work on high prevalence conditions such as obesity, otitis, encountered across many pediatric settings, and less common, higher acuity areas such as improving supportive care for children with cancer. He serves as the lead investigator for Data Coordinating Center of PEDSNet, a multinational center for pediatric collaborative operating as part of the PEDSNet national network to enhance data sharing and the efficiency and real-world impact of clinical research. Dr. Bailey.
All right, well, thank you very much for taking the time to listen and giving us the opportunity to talk here. I'm going to start by apologizing in advance for a bit of font troubles in the transition from Mac to PC, but hopefully things will go well with the actual data. So I'm going to start with the disclosures, which speak for themselves, no conflicts to declare, and the usual pediatric reservations. Right? And then I want to follow that up, first and foremost, with an acknowledgement that the information I'm going to talk about is dependent, as are most of the data sources we're talking about today, not just on the work of those of us who are fortunate enough to be entrusted with the data and do the analyses, but also on the hundreds and thousands of people who are contributing their health information and their anthropometric data. All right. Having said that, let me just start with a little bit of background about PEDSNet so you can understand the context in which we're working. This is a collaboration of 8 large pediatric health systems in the US built around learning health system principles. Broadly, PEDSNet as a network is intended to accelerate clinical research by facilitating not just data sharing, but also creating a common regulatory framework and methodologic support, particularly for secondary use of EHR-derived data. And in that context, we're operating as one of the clinical data networks within the larger PEDSNet network that I believe was mentioned earlier in the panel discussion. Right? If you look at the distribution for the network, we're scattered fairly broadly across the United States, but as you might expect from a collaboration of academic health centers, in each region, PEDSNet sites tend to be located in larger urban areas affiliated with universities. So from a data perspective, we're going to overrepresent urban populations, and we're going to underrepresent more rural and more rural populations and smaller practice networks. All right. Having given you that organizational structure, what I want to spend most of the rest of our time talking about is the use of data derived from electronic health records. So in essence, we're not talking about a new source of data. Right? Clinicians have been measuring anthropometrics, particularly for children, using fairly standardized methods and fairly standardized equipment for decades. But what is new is that most of those data have been sort of stored away in individual specific paper charts and really not available in the way that survey data have been for the study of populations. The transition over the last decade to broader storage of health records in electronic form, and in particular, some targeted initiatives as part of the Meaningful Use program around the collection of anthropometric data, have created the opportunity to collect healthcare-derived data impacting on obesity in large populations, and to be able to use those populations to construct both cross-sectional and longitudinal samples, and to connect the anthropometric data to large amounts of other health data. Right? So the potential here is to get a broad representation of the population with a large sample size, allowing always that there are users and non-users of health systems, and in our particular case, users and non-users of academic health systems, and that carries its own source of bias. The other nice thing about sourcing these data from medical records is that it connects the information on growth and on obesity with a broad set of data elements that both provide a we hope comprehensive, I don't want to overstate it, picture of the health of children, and that also connect the data that we're using to measure growth and obesity with the kinds of data that are actually being used to drive decisions about the care of these children in health systems. All right, I have to say, having talked about some of the potential of EHR-related data, I also need to call out early on some of the limitations. And one in particular that I want to focus on is that this is fundamentally observational data. So the impetus for collecting these data are providing clinical care to usually individual patients, in some cases populations of patients within a health system. But that is the driving workflow. And when anthropometrics are measured, when clinicians choose what to measure and not to measure, when the intervals between measurements are determined, it's driven by those clinical workflows and not by the kinds of regular intervals or detailed protocols that we do see in carefully crafted national surveys. Other things worth noting, I don't want to underestimate the technical barriers. I think one of the panelists before mentioned that companies like Epic and Cerner have not been particularly invested in, I believe, what he called live data. I am happy to say from our perspective that has gotten much better in the last 5 to 10 years, but still, EHR vendors are vendors of operational software. They each have their own data model. They each have their own way to get the data into the system, and they each have their own way to get the data out of the system. Things like anthropometrics are relatively insulated from some of these problems. A kilogram is a kilogram is a kilogram, but still, when data are captured, how they're annotated, things like that will differ from site to site. Also worth noting that while interoperability is a big word in clinical informatics circles, it is mostly something that looms large in potential as opposed to in practice, and the standards for actually collecting and exchanging these data, both on a technical and on a regulatory level, are in their infancy. All right. Having given that broad introduction, let me talk a little bit about anthropometrics in particular. When we're talking about obesity in children, we have the particular advantage that these are a routine part of pediatric care. So I mentioned that clinical care is the driving workflow for this. For children in particular, measuring growth is one of the things that we do to assess the health of children. And so this is a routine part of medical care. If I see a patient, I can't dose a medication accurately without a good weight. And so weight measurement is something that happens repeatedly and fairly accurately. In particularly more densely settled areas, the likelihood is high that at selected grade levels, when children enroll in school, someone's going to ask them for information from a well child check. That includes things like height and weight, so more impetus to collect those sorts of information. Okay? The other nice thing, as I mentioned, is that a kilogram is a kilogram is a kilogram. And so while we have to worry about interconverting pounds and kilograms, we don't have to worry about whose impression we were recording. Okay? One of the limitations I want to call it early is that in our experience, the data that are available in medical records are largely anthropometrics, so good screening data, good ways to look at populations, but people are not in general doing a great job of capturing things like waist circumference or skin fold thickness or other perhaps more accurate measures of adiposity. The other thing that I think we had a lot of concern about going into the use of EHR data for measuring growth and obesity is that there are not the kinds of detailed protocols for instrument calibration and repeatability of measurements, particularly in younger children. And so we had some concerns about variability, and I'll show you some of what we found as we go forward. Right? So I'm first going to describe a pilot study that we used just to assess the value of these kinds of data in electronic health records. 6 of the 8 PEDSNet sites participated in this, and essentially what we did was we collected all outpatient visits for a 2-year window and asked for demographic data for measured anthropometrics and for recorded diagnoses where those were available. We then used those data to compute BMI and estimate prevalences of obesity and associations between obesity and other aspects of healthcare. I will point out here that one of the things that we did was conservative imputation of height, and we did that because weight is measured more frequently than height, and because we were able to establish that using sufficiently conservative imputation techniques, height, which is less variable from visit to visit, could be reliably imputed, and that allowed us to derive BMI at a significantly higher fraction of visits. All right, so this pilot study generated data on a population of just over 800,000 patients across six academic centers and about 3.5 million visits. Right? If you look at the demographics, they're reasonably reflective of what you would expect in densely populated areas, so a slight female predominance in line with national census data, and the kind of utilization that you would typically expect in pediatrics. So it may be a little hard to read the legend, but the big purple wedge are kids older than 5. We have some oversampling of kids in the 1 to 2-year-old range, because what drives their utilization is not just acute infections of childhood, but child checks. And in the current schedule, there are about 7 of them in your first couple of years, and then things settle out to once a year thereafter. If you look at the sites of care, again, accounting for the fact that this represents 6 particular practice plans, what we saw was that about 60% of the values were measured in a primary care setting, the remainder in specialty cares. That includes things like acute emergency department visits. So that tells you where our data come from. Let's talk about the quality of the data a little bit. The first thing we asked was, how often were we missing data elements? Again, this is a fairly simple survey. We're looking for demographics and anthropometrics. But what you'll see here is that the missingness of data elements was well under 1% for all of the sites. So we were able to retrieve these data elements from EHRs and make use of them fairly consistently. Right? If we look specifically at anthropometrics, you see a couple of things here. Right? The first is that the limiting factor in measuring BMI is the measurement of heights. Right? So the blue bars are telling you what proportion of visits had measured heights. The red bars measured weights. And you can also see that there's a fair amount of site-to-site variation, right? Most pediatric sites with primary care networks are measuring well over 50%, but one site in particular, which really doesn't have much of a primary care component and so has a higher representation of acute visits, has much lower rates of measurement. We also looked at the quality of the data, and we tested a bunch of pragmatic measures. I'm showing you here a subset. So the first 3 rows give you information about what we call unit errors on heights, weights, and head circumferences. So these were cases where we had multiple measurements for a given individual, and if we follow those measurements over time, we saw, for instance, in height, a series of measurements, and then a measurement that was about 2.5-fold the prior measurement, and then a return to baseline, or the reverse, indicating that someone probably missed the conversion from inches to centimeters. Similarly for weight and head circumference. Those actually occurred surprisingly infrequently. So again, well under 1% of the time were we seeing those kinds of unit conversions, and they were easily detectable. Administrative errors were also fairly low. Again, a concern of ours because there's not a lot of regulation at the point of data capture, which is often at the point where a family checks in with a unit clerk or a scheduling clerk in a clinic. We saw an almost undetectable rate of change in recorded sex and a very, very low rate of decrease in age, something we would have expected for about everyone who doesn't make it into a movie to be monotonically increasing. Interestingly, there are places where you can see significant changes that fall out of practice, right? So I called one of them out here, and that's decreasing height. So when we set a 2% threshold, which is a decent one for the purposes of discussion, you can see of the 5 sites reporting this measure, one site reports a 12% incidence of kids who get smaller from one visit to the next, right? Again, this reflects the demographics of that particular site and is kind of a caution to people using these data. It turns out that this site had a relatively low representation of infants and adolescents, and for some odd local reasons, had a relatively high representation of preschool children. And so what we were detecting was the change from recumbent length to standing height in children around their third birthday. And if you account for that or increase the threshold to about 5%, all of these sites are well under 1%. So again, we're coming out with data that are reliable, at least from measurement to measurement over these systems. And you can see there's a fairly low rate of actual wildly implausible values. We're using standards similar to the CDC for wildly implausible. So, z-scores of less than -3 or more than 3, except for weight, where you can go up to 5. What we did see was a huge volume of data. So this is a very simple figure that's just stepping through childhood month by month and asking how many data points did we have for BMI. And in this sample, for each month of age, we had more than 5,000 measurements of BMI for any point under 17 years of age. So that allows us to do things like subset analyses, where we can give you information on different demographic groups or geographic groups. It also allows us to try to detect rare health-related events in these data. But only if these data are actually accurate as well as reliable. So I did a couple of things to try to compare them to outside data sources. Right, the first, again, was to look at the gold standard, NHANES. Right? So what I'm showing you here is, for girls, the mean BMI month by month of age from 2 years to 18 years of age. The green line is the weighted average for NHANES. The little crosses are the month-by-month point estimates from the NHANES survey. The red line is the EHR-based estimate. So what you see is, again, you get a fairly accurate reproduction of the 50th percentile, in this case, of a growth curve for this population. The biggest difference between the two is that you don't see the hysteresis in the EHR data that you see in the NHANES data for these month-by-month subsets, because you're measuring 5,000 or 6,000 kids at each point instead of about 17 kids at each point. The other thing we looked at was site-to-site variation. So this is just an empiric cumulative distribution of BMI for each site. Again, black is the NHANES distribution, and you can see that the curves for each site look fairly similar. There are certainly differences, reflecting some geographic differences in prevalence of obesity, as well as some differences in the age groups captured. But while you can detect those differences and you can use them to look for practice variations, we were happy to see that you weren't seeing wholesale changes from site to site in distribution of body mass index. Right, so what does that get in terms of the central tendencies or the overall estimates that we've been talking about? What we're showing here are the cross-sectional estimates for prevalence of obesity and overweight, but not obese. And we actually measured these in our data set as patients who were ever obese at any visit, or who were overweight but never obese at any visit. Again, we found, depending on which subset of the data you looked in, that was stable at better than 50% or better than 70%. In other words, if you were obese at any point, there was a better than 50% or better than 70% likelihood that at all of the visits where you had BMI recorded, you would fall into the same category. And what you see on the top is recomputed estimates for the 2007 to 8 NHANES biennium. And then on the bottom is the same time interval for the PEDSNet data. Overall, what you see is we have a relative overrepresentation of toddlers, again, consistent with provision of medical care. And our estimates track the NHANES prevalence estimates very closely in all populations except those toddlers, where we see a slightly higher prevalence of obesity. We have not adjusted the EHR-based data for race and ethnicity in this figure, because we were specifically looking at the feasibility of EHR data as a readily available measure to be included in other studies. So here, our relative overrepresentation of particularly African American and Hispanic children in urban areas may also be part of what's pushing our estimates up. We also wanted to look at the administrative side of healthcare and ask how effective would administrative data be as a measure of obesity in children. I think, probably to the surprise of very few people in this room, we're not very good at diagnosing obesity. So what you're looking at here is the frequency in a bunch of different specialty contexts with which a child who, based on BMI criteria, would be called obese, actually attracted that diagnosis anytime in the 2-year period. And the short summary is outside of dedicated weight management clinics, no one was making this diagnosis more than about a third of the time. Endocrinology, who was managing diabetic children, followed the weight management clinics, but primary care was not doing significantly better than most specialties. And as you tail off toward the right, unsurprisingly, I think my colleagues will throw rotten fruit at me, the surgical specialties were not perhaps focusing quite so much on things like growth trajectory as some of the medical specialties. So since we weren't seeing obesity as a common diagnosis, we asked, what were we seeing? Again, the most common diagnosis at most sites was, well, child check, right? So it was not for lack of opportunity that we were not seeing these diagnoses recorded. And we were seeing also a number of diagnoses for secondary comorbidities. So there are a variety of factors that go into whether or not you record a diagnosis of obesity, but we're certainly seeing things peppered around it. Two take-homes for us from these data. The first is that, at least when studying obesity, we're not very enthusiastic about using administrative data, since walking in, you miss 70 to 80%, or you misclassify 70 to 80% of your affected individuals. The second is, again, you need to be sensitive to the clinical workflows. You can see well child check appearing as a common diagnosis in all except the rightmost common here. And you can see obesity appearing in the top 3 diagnoses for obese children in all except the rightmost column here. It turns out that due to quirks of the way data are collected in the EHR at that rightmost site, when you wanted to say someone was overweight, the diagnosis code, the code that was recorded was not obesity, it was abnormal weight gain. And if you didn't know that that ICD-9 code, which was not part of typical clusters, was that site's way of recording obesity, you'd miss it entirely in administrative data. Okay, so from this simple pilot, I think the conclusions I would advance are that the EHR provides reliable and substantially accurate data for tracking growth, overweight, and obesity in kids. It provides those data on a broad cross-section of children, at least in these catchment areas, most of whom have at least periodic contact with the healthcare system. The data have lower than expected rates of internal inconsistency and high concordance with resource-intensive national survey data. Right? The next question we asked was, given the breadth of the data we had and its location in a healthcare system, are data from these sources useful in detecting some of the health-related outcomes that we're interested in trying to measure obesity? So I'm going to show you two views into that. The first, as I mentioned, we collected, as part of this pilot, diagnostic information from 5 of the 6 sites. And so we asked, within this sample, with what diagnoses could you detect significant associations with obesity? And if you look here up at the top with the strongest associations, you know, we certainly see the comorbidities that we're all familiar with, right? Type 2 diabetes, hypertension, sleep apnea, hyperlipidemia, that sort of thing. But it's also worth noting that we can detect a significant association with acute leukemia. You know, as an oncologist, that's no surprise. We give kids lots of steroids, so that's an association we've known about, but it's been hard to recover from data. Right? We can detect associations without cause-effect comments with rare neurologic disorders like seizures and multiple sclerosis, with septicemia, with nephrotic syndrome, again, probably also driven by steroids, and so on. So this gives us the ability to subset the data and look for rare events while still being able to rely on primary data to screen for obesity. All right, we wanted to take a bit of a next step there and ask what other healthcare-related risk factors might we be able to detect in these kinds of data. So we turned to a bit of microbiology, and in particular we were motivated by, on the one hand, the growing body of evidence that the gut microbiome is one of multiple determinants of obesity, and on the other hand, that among the most common medications prescribed to children under 5 are antibiotics, right? Usually to treat strep throat, ear infections, and similar sorts of things. In particular, the concern has been raised that exposure in early childhood may actually target a critical period for stabilization of the gut microbiome, and so it may have a disproportionate effect on risk of obesity. So I'm going to show you data from a single health system here, where we sort of took a a deeper data pull. These data are being now replicated out into the other systems, but I'm going to talk about longitudinal data over a 15-year period from the Children's Hospital of Philadelphia catchment area, so southeastern Pennsylvania, Delaware, southern New Jersey. We accumulated from these data what I won't quite call a birth cohort, because we were actually only requiring that you start follow-up within your first year of age, but a longitudinal cohort of about 65,000 children who established follow-up within their first year after birth, and then who continued their follow-up for at least 3 years, and in about 60% of cases for a full 5 years. Right? We measured antibiotic exposure in the first 2 years after birth, and then growth outcomes in the 3 subsequent years to look for associations with preschool age obesity. In terms of demographics, this looks like a lot of the PEDSNet centers, right? So about a third of the sample lived in within city boundaries, about 2/3 lived in fairly dense suburbs within about 60 miles of the city. About half came from a racial or ethnic minority, and about 40% at some point during the period reported coverage with public insurance as a sort of very crude estimator retrospectively of socioeconomic status. All right, as expected, antibiotics were the most commonly prescribed medication in the first 2 years of life. And if you look at the top bar here, what you'll see is about 2/3 of the children had some exposure to antibiotics, with, for about 15% of these kids, those exposures coming before 6 months of age, and with the peak being around a year of age. We divided the antibiotics into broad and narrow spectrum, partly based on microbiologic spectrum, but so that the microbiologists won't throw rocks at me, also partly based on existing evidence-based clinical guidelines. So narrow spectrum antibiotics included those that were intended to be first-line antibiotics for treatment of common childhood infection. And of note here, about 40% of kids were exposed to broad-spectrum antibiotics. Right? We looked in multivariate models that adjusted for demographic factors, for socioeconomics, for common comorbidities like asthma, for exposure to other drugs such as steroids that we felt might be correlated with obesity, and for practice-by-practice subset interactions, and asked, were exposures to antibiotics associated with an increased hazard of obesity in early childhood? What you see on the left is the results by number of exposures, and on the right by age at first exposure. The brief summary you can take right off the forest plot is that increasing exposure to antibiotics was associated with a modest increase in risk of obesity, and that in particular, this risk appeared to be associated with exposure to broad-spectrum antibiotics. Multiple exposures to narrow-spectrum antibiotics, despite being more common, and exposures to narrow-spectrum antibiotics at any age were not significantly associated with the increased risk of obesity. I mentioned we looked at a bunch of other risk factors, and we recovered most of the risk factors you would expect in this set. For quick summary, the italicized terms here are risk factors whose effect size was larger than antibiotic exposure, and the non-italicized text were risk factors whose effect size was the same as or smaller than. Interestingly, things like steroid exposure was not more strongly associated with the risk of obesity in the overall healthy population than antibiotics. Worth noting as a study, this has significant limitations, right? It's observational, it's based on healthcare utilization, it's looking at the practice patterns in a single academic healthcare network, and we're using the data within that network to capture in particular medication exposures, right? So we have limitations in capturing out-of-network exposure, and we have limitations in detecting unfilled prescriptions. Also worth noting that the effect sizes are small, and I mention that because these data have been replicated in a number of other cohort studies, but as you jump from study to study, you can see the subsets of the population in which these associations are a significant shift. In some studies, it's early exposure to antibiotics. In one large Canadian study, it was males but not females. In other studies, it's type of antibiotics. So again, highlighting for us the fact that we need the size of the data and we need the longitudinality to be able to look at these sorts of associations. The other thing that I have to note is that this was a utilization-based study, and so the sort of glaring omission from the data set are the kinds of environmental factors like more detailed socioeconomic status, amount of exercise, dietary factor, duration of breastfeeding, and even things like maternal weight gain that we would love to know. So these are things that, in the future we need to work better on capturing. Again, we have a window into that with healthcare utilization. All right, for the sake of time, I will leave the slide up and say that there are additional extensions being done to more broadly replicate this and to try to add patient-reported data and information about secondary screening to this kind of armamentarium, but I think that's kind of peripheral to the use of this as a potential method for collecting data about anthropometrics and obesity. So let me stop there and ask if anyone has any questions. Thank you very much for your time.